Welcome to our presentation on medications and osteoporosis based on the 2023 Osteoporosis Canada guidelines. To help frame our presentation, we will discuss Dan's story, which is similar to that of many of the patients we see in clinic. Dan is a 68-year-old man who was diagnosed with osteoporosis based on a bone mineral density test that was ordered by his family physician, as he had been falling frequently. He is wondering what his options are for medication that can help manage his condition. If you have been diagnosed with osteoporosis and are looking for ways to manage osteoporosis with medication, then this presentation is for you. Here is an overview of the topics that we will discuss today. We'll start with an introduction, followed by decision to start treatment, treatment options, continuing treatment, good practice statements, some resources, and end off with conclusions. To start, there is strong evidence that medications significantly reduce fracture risk in people with osteoporosis. Osteoporosis Canada recommends medication management for postmenopausal women and men over 50 who are at increased risk of fracture, emphasizing the importance of treatment. All patients should also receive proper counseling on nutrition and exercise to optimize bone health and prevent fractures. For more details on these topics, please refer to our dedicated presentations on nutrition and exercise. Who should start an osteoporosis medication? To determine if osteoporosis medication is needed, your doctor will first assess your fracture risk. This includes reviewing your history of fractures and risk factors for osteoporosis. Based on their assessment, further tests such as bone mineral density testing or spine imaging may be considered to guide further treatment decisions. Starting osteoporosis medication is recommended for individuals at high fracture risk. This includes those with a history of previous fractures from low trauma, such as hip, spine, or multiple fractures, age over 70, and a diagnosis of osteoporosis based on bone mineral density testing, and high fracture risk based on tools like the FRAX calculator, which uses your age, gender, BMD, and other clinical risk factors to calculate your 10-year absolute risk of a hip fracture or other major osteoporotic fracture. These criteria help identify those who would benefit most from treatment. Medical treatment can also be considered for individuals with a moderate fracture risk depending on other factors. These include those aged 50 to 70 diagnosed with osteoporosis based on bone mineral density testing, and individuals with moderate fracture risk based on calculators like FRAX. Importantly, treatment is not recommended for individuals with a low fracture risk. For individuals who meet the criteria for treatment, bisphosphonates are the first-line recommendation. We will discuss in more detail later in this presentation. For some women experiencing significant menopausal symptoms, hormone therapy may be considered as an alternative to address both osteoporosis and menopausal concerns. For individuals who qualify for treatment but cannot take bisphosphonates, denosumab is an effective alternative. It's important to note that once started, denosumab should be continued indefinitely. For patients at very high fracture risk, such as those with severe or multiple spine fractures, consultation with an osteoporosis expert is advised to consider anabolic therapy, particularly for those who have not previously been on treatment. The following are the main classes of osteoporosis medications. 1. Anti-resorptive agents. These decrease bone breakdown and include bisphosphonates and denosumab. 2. Anabolic agents. These stimulate new bone formation and include teriparatide and romosozumab. And 3. Hormonal therapy. Options include menopausal hormone therapy and raloxifene. Moving on to talk about specific classes of medications. Bisphosphonates are highly effective at reducing fractures. Over 3 years, for every 1,000 people taking bisphosphonates compared to no treatment, we would expect 20 to 30 fewer spine fractures, 10 fewer fractures in other bones, and 3 fewer hip fractures. Common bisphosphonates include alendronate and risedronate, available as weekly or monthly pills, and zoledronic acid, which is administered yearly as an intravenous infusion. Bisphosphonates can cause short-term side effects with less than 3 years of use, such as esophagitis and ulcers, which are uncommon, and flu-like symptoms with zoledronic acid. Rare side effects include atypical femur fractures and osteonecrosis of the jaw. that increase with long-term use. For this reason, we do not recommend treatment for longer than 6 years without a drug holiday for most patients. If you have kidney disease, you should discuss with your doctor before starting treatment. Here is an infographic from Osteoporosis Canada demonstrating that the benefits of bisphosphonates at a population level far outweighs the risks. Over the course of 5 years, out of 100,000 people on bisphosphonates, 2,500 will likely avoid a fracture, and only 25 may experience a serious side effect. Now moving on to denosumab. It is important not to miss or delay injections scheduled every 6 months. Missing, delaying, or stopping denosumab can cause rapid bone loss and increase the risk of spine fractures. Due to this risk, denosumab is not typically first-line treatment. Denosumab is usually continued indefinitely. If the decision is made to stop, you will need to be transitioned to another medication, often requiring consultation with an osteoporosis expert. For those starting bisphosphonates, you can expect an initial treatment duration of 3 to 6 years. For denosumab, it's important to remain on long-term, uninterrupted treatment. If you need to stop, you'll have to transition to another treatment. After completing a course of anabolic therapy, it's recommended to switch to an anti-resorptive agent in order to maintain bone density gains. Bone density measurements are recommended 3 years after starting treatment. Your bone density measurement may be repeated at a shorter interval for those with secondary causes of osteoporosis, new fractures, or new risk factors associated with rapid bone loss. 3 years after stopping bisphosphonate therapy, bone density is recommended and clinical assessment of fracture risk in order to determine the need for resuming therapy. We will now share some good practice statements over the next couple of slides. Before starting treatment, your doctor will evaluate for other causes of osteoporosis and consider the potential benefits and risks of starting specific medicines. If there's uncertainty about your fracture risk or treatment options, it's recommended to seek advice from a specialist in osteoporosis. If bisphosphonates are not working well for you, or your fracture risk remains high, your treatment may need to be adjusted, and your doctor may look for other possible causes. It may also be helpful to consult an osteoporosis expert. You should have regular checkups to monitor for new fractures, any changes in risk factors, and to review your treatment plan, including any side effects. You should also receive guidance on how to monitor for symptoms or side effects from osteoporosis therapy, such as gastrointestinal symptoms or new groin or thigh pain, which could be a sign of a rare atypical femur fracture. Here's a link to the Osteoporosis Canada treatments page for additional information. In conclusion, osteoporosis medication is effective in preventing fractures. Your treatment plan will depend on several factors, so it's important that you discuss your case with your doctor.